This is a lecture I gave back in October 2020 for the Oswestry foot and ankle course on heel pain and Achilles tendon. There's also another lecture on Achilles tendon ruptures that's already on the Liverpool foot and ankle YouTube channel. If you haven't subscribed yet to this channel, please subscribe. The updates throughout the year. Thank you.
So it gives me great pleasure again to introduce our next speaker, who's Professor, Hunterian Professor for the Royal College, Lyndon Mason. And, he works in quite a large trauma centre as well. It's a collaborative, I gather, Lyndon, Cheshire and Mersey. Lyndon's going to talk to us on heel pain and the tendon Achilles and how to manage. Again, a big topic, so listen tightly. Thanks, Lyndon.
Can everyone hear me?
Yes.
Hi. So thank you for the introduction. So yeah, I work in Liverpool University Hospital Foundation Trust, which is a very large trust now. There's 7 foot and ankle surgeons working together. We specifically we have a heel pain clinic we've had for the last 4 or 5 years, tertiary referral clinic. So when you got recalcitrant heel pain, they get referred to different hospitals into the unit. It's actually run by my colleague Phil Elson, who's a specialist physio, and I'm the consultant lead for the clinic. So unlike your previous talk, where it's very specialized and very rare, where Prof Stephen said at the end that the evidence is mainly level 4. Almost everything I'll talk to you about now is level 1. The difficulty with heel pain is that it's many different conditions with the umbrella term of heel pain and Achilles. It's sometimes very difficult to decide between them or which diagnosis it is. And you have many, many different treatments, all of them interacting with one another. And there's definitely a regression to the mean. So most of it would get better anyway. And it's trying to decide which one we should use. Also, everyone is susceptible to confirmation bias, and I'll try my best to stay away from confirmation bias today, but we are all susceptible to it. So I'll go through the anatomy, the diagnosis, treatment, and then the post-surgery. So first of all, the anatomy. So we have the plantar fascia, the Achilles, Baxter's nerve, and tarsal tunnel. And these are really the 4 anatomical structures that will really cause the pain for the heel pain and Achilles that we get. So first of all, the Achilles. The Achilles starts above the knees, the gastrocnemius. These are the 2 heads of gastrocnemius, medial and lateral. And the soleus, which is on the back of the tibia and fibula, it's in the superficial compartment of your leg. And as it goes distally, they fuse together into a tendon called the triceps sureo Achilles tendon. You can see how with the aponeurosis of your gastrocnemius attaches to your soleus here. As it descends down to the distal aspect, you can actually trace each element of the muscle down to where it inserts. And as you can see, it rotates around where as you can see, this is a little bit easier to see. This was an anatomical study by one of my colleagues, Mr. Malloy, in the BJJ a few years ago. And your medial head of gastrocnemius arrives at the most posterior aspect. So as you can see, it corkscrews, and your medial head of gastroc ends up at the most posterior structure. This is quite a common question, actually, in your single best answers for FRCS. In regards to your vascular anatomy, the proximal and distal sections are from your posterior tibial artery, and your middle section, where you often get your non-insertional Achilles tendinopathies, seen as a watershed area, comes from your peroneal artery laterally. This is important also if you're doing ankle fractures from the back, because if you decide to do a approach right next to the tendon Achilles on the lateral side, which is written about, or you've got the sural nerve, which is also at risk, but you can also take away its blood supply from this section. As you come down, this is a paper from the Journal of Anatomy in 2013. You can see that the Achilles tendon wraps around and becomes a very, very thin structure before it then becomes your plantar fascia. And your plantar fascia is really a component of your tendon Achilles. And as we've evolved, the calcaneum has become kind of a sesamoid, like your kneecap. It's become a sesamoid to allow the force transmission through to the front of your foot. And the plantar fascia then continues on to the front of the foot, where it attaches to the metatarsal heads, and this is what gives you windlass mechanism. On the medial side, you go your tarsal tunnel. This is your neurovascular bundle coming underneath the flexor retinaculum before it descends down into the plantar aspect of your foot. Your abductor lucis, and as you can see by this anatomical paper, also the aponeurosis can cause compression of a number of nerves coming down, not only through your tarsal tunnel, and specifically Baxter's nerve, which was written about a few years ago. The first branch of your calcaneal nerve can be compressed in a number of different areas in between your two muscles here, or underneath as it comes underneath your calcaneum. And if that happens, you can get this muscle can become denervated. We'll talk about it later. And lastly, not to leave out the plantaris muscle, which is seen as an etiological reason for some Achilles tendon pain. And there are different insertions you can get. This paper looks at the different insertions, and certain insertions causing problems with the Achilles tendon. You can see the plantaris muscle here on the back of the knee, and it descends down. There's thought to be not any functional use of it anymore, and it seems to be an anatomical remnant from evolution. So pathology-wise, so for heel pain, the terrible triad is something that you should keep in mind, because this is your first line of treatment anyway. So less than 0 degrees of ankle dorsiflexion, 23 more times likely to have plantar heel pain. Calf tightness is by far the most common reason for heel pain and Achilles tendons. Your obesity, so the heavier you are, is 3 times more likely to have plantar heel pain. And if you spend all the time on your feet in your jobs, these are the patients that you'll see. This is a paper brought out this year in 2020, where they correlated the pain that they get in your heel and your calf tightness. So the more tight your calf, your gastrocnemius specifically, the more pain you get. Weight matters because on walking and running, it's not only your body weight, but 3 times your body weight and 8 times your body weight with the Achilles tendon. See the same with plantar fascia and plantar ligaments. So even a small amount of weight loss for your pound weight loss would be 8 pounds weight loss in your running. It's not just the physicality of the weight. The central fat, tenocyte inhibition, hyperlipidemia can cause all problems with the tendinopathy itself. Your gastrocnemius is quite important. This is something that is believed by some foot and ankle surgeons, but it's not ubiquitous across the foot and ankle community. I am a believer, so I note my bias. But your gastrocnemius attaches above your knee, and as you progress forward, if this structure is tight, what happens is that you have down the chain, you have increased stress across the Achilles or the plantar fascia, forefoot pain, tib post pain and such. So the tighter this is, the more problem this comes. And this is a consequence of the way you sleep at night. So in my practice, if people sleep, usually they say they sleep on the side, but they sleep in this side recovery position with your foot in equinus. You can see the foot in equinus here. And these the pain. And usually it happens in your 30s as the tendon's getting stiffer. And only that, over the age of 30, the time you spend in that position and the time you actually position shifts and long postural immobility, when you hit your 30s, you can see you're in that position for a long period of time. And that is when we see the tendinopathies and plantar fasciopathies coming in. So really your terrible triad is me, overweight, belly sleeper, weekend warrior, and works on my feet. What's the path mechanism? So this paper back in 2009 by Cook and Purdom, they talked about the 3 different stages. We had reactive, disrepair, and degeneration. That the reactive is the initial phase and the disrepair is reversible. But if you get to degeneration, you've pretty much lost the boat and it's irreversible. In 2016, they revised this to say that even though it's irreversible disc repair, you can treat it to get pain-free and function in this tendon, but it will remain degenerate. And this is quite important for Achilles tendon ruptures, for example. So Achilles tendon will have this area disc repair, but it may be pain-free when it ruptures. So if you most histology of your Achilles tendon ruptures will find an area disc repair. So diagnosis, I go through the clinical examination investigation. So history is usually worse in the morning, except for pump bump. Improves with walking and deteriorates towards the end of the day. And the important differentials are tarsal tunnel syndrome, usually pain at rest and relieved by weight bearing. Pain at rest and relieved by weight bearing is a red flag. Recent increase in activity, think about stress fracture. If there's a burning global type pain, think of a bursitis neurological. Personal history, inflammatory conditions, other joint pains, back pains, neuropathic conditions, and diabetes. Depression, anxiety, and stress feeds into it. This paper showed that it was an odds ratio of above 1 for every 1 unit of depression, anxiety, or stress. On examination, this is difficult. This is actually from one of Mr. McQuarna's paper, but I've added it to it. So you got on this median malleolus, it's got different areas which are associated with pain, but in truth, they all globalize. But you have your tibialis posterior, medial calcaneal nerve, Baxter's nerve, non-insertional plantar fascia, insertional plantar fascia, insertional Achilles tendon, radiculopathies, calcaneal fractures, fat pads. So you can see there's a number of different conditions. It's very difficult. So apart from pump bump, which doesn't really get pain from on rising from the bed, and it's really the rubbing of the shoes which is the problem. The pain at the back of the calcaneum can be symmetric or asymmetric. If it's asymmetric, it can be insertional, can be medial of insertion, diffuse, superior to insertion, different conditions. But in truth, they all mirror each other. There are tests that are indicated. Silver skull test, which is your testing of your gastrocnemius tightness, is important for all the patients. And this is essential in anyone you are looking at their Achilles or plantar fascial pain. The passive dorsiflexion, dorsiflexion eversion tests, I'll show you now in the next paper that even though these were seen to be specific, they're not specific at all. And resisted great toe flexion is for your FHL. So this was, they tested mechanically both tests and showed there was no difference. For suspected calcaneal fractures, the squeeze test, so you squeeze both sides of the calcaneum, kind of illustrates this stress fracture. For imaging, weight-bearing lateral radiographs to rule out fracture or tumor. This is usual in my practice, so everyone gets a lateral radiograph. Another imaging for reserved atypical cases, so the MRI, good to rule out other disorders. Ultrasound for plantar fascia thickness is 4 millimeters, 100 times more likely to have plantar heel pain. But if they've got a heel spur, it doesn't mean that they've got plantar fasciitis. So this is the MRI, for example, a Baxter's nerve neuropathy, and you can see fatty infiltration due to a denervation of your adductor digiti minimi. This is a MRI shown in the tarsal tunnel, a ganglion, a fluid-filled cyst. And when this was explored, you can see this ganglion here. You can see this one was a schwannoma of the tarsal tunnel. So the MRIs can be useful on occasion. So treatment, this is where it becomes very difficult because there is so much in the literature. I've done this talk now, I think 3 years in a row. Every year I've updated it. It takes me 4 to 5 hours of reading through the 20, 30 papers that come out that year to just include it. So we've got plantar fasciopathy, insertional Achilles, and non-insertional Achilles. So plantar fasciopathy, so the conservative managements, first line, reduce the mechanical overload. So lose weight, reduce calf tightness, and change activity. However, if you do nothing, it used to be, I was taught that there was a 2-year burnout with plantar fascial pain, but actually this paper, which was a 15-year follow-up, showed that at 15 years, 40% was still had plantar heel pain without treatment. The main form of treatment is plantar fascial specific stretches. This is from the 2 papers here from JBJS America by Dia Giovanni. they found that in 2003 and 2006, they had patients which, if they compared it against doing normal eccentric stretches of the calf, they made a big difference. And this is how you could see this. So this was the plantar fascial, this was your Achilles stretch, but both of them actually improved, but one improved quicker than the other. Steroid injections. So in vitro studies have shown that tendon and fascia fail and lows decrease approximately 35%. But one level 1 RCT against stretch exercises showed actually a statistical improvement at 3, 6, and 12 weeks, but no difference at 1 year. So it didn't last long. But the reason why I include these two to start with is because these are now the placebos for every other voodoo magic that we put to it. So it doesn't mean that the other treatments, whatever treatment, snake oil or anything you're going to put on these heel pains, it doesn't mean that they don't work, but they are now being compared against something we do know work. So all these now are saying, do they work against the stretching or the steroid? So this one, different treatment modalities, plantar fascial pain, 140 patients, plantar fascia is divided in 4 groups. They had just normal analgesics, heat and silicone heel pads, plantar fascial stretching, calf stretching, and the stretching exercise were the most significant improvements in functional scores. Night splints, so this was introduced about 20 years ago. The problem with night splints is tolerance. So even though the first step out of bed in the morning is the problem, the way you sleep at night is the problem, these splints are not well tolerated by patients. There's an RCT between night splints and home exercise, and there's no difference in pain between the groups of 3 months. But they did say that they didn't know whether or not these were actually used by the patients. Multiple treatments, so 43 articles evaluating 2,837. They looked at insoles, relieving symptoms of the heel caps. And they found that combining night splints or rock soles enhances the improvement of pain relief if you combine them. So it's an additive effect. So yes, you may use a splint, you may use an insole, you may use a stretching, and the more you add on, if you just don't compare them together, they have an additive effect. It's synergistic. So this is the kind of thing for a nighttime splint. You can see if they're a belly sleeper, they have this tenting effect and they just don't like it. We are currently developed this, which is goes underneath the sheet to try and improve it. We currently had some very good initial results from this, but it's not gone into RCT. Meta-analysis on conservative treatments. This was published in 2017, included 20 studies. Shockwave therapy showed a low quality of evidence of improvements, so the laser therapy, so the orthotics, so the other treatments, but this is the table I want you to get to. And you can see that even though, compared to the placebo, which was the injection by steroid or stretching, which we know work, some of them did improve, not all. So these ones did improve it, but there's no clinical improvement. So these patients improved statistically, but not clinically. PRP, the magic that's come over from the States, 10 RCTs comparing versus steroid, overall improved, not statistically significant as compared to the other treatments, but it was at 12 months. It seems to be a longer lasting effect than, say, a steroid. Human amniotic membrane, statistical improvement compared to steroid, however, only 18 weeks follow-up, not clinically significant. Radiofrequency neural ablation, it was not an RCT, it's a level 4 paper. And this is the ultrasound the nerve and then injected into the nerve and then done a radiofrequency ablation. Botox, this one paper did show a significant both clinical and statistical significance. You can see the VAS at 12 months. For placebo was still quite high, but it was a significant difference. But then published only this month, Botox, RCT versus anesthetic or steroid. And then again, there's no difference. The surgery, so the Gastroenterous Release, this was from the Surrey, the Guildford group. Initial level 4 evidence, 81% total pain relief, 58% reported improvement. This has now gone into a level 1 study versus stretching, showing significant improvements, FRCS, FAS, and SF36. And in our unit, this is the go-to treatment for recalcitrant heel pain. that has not responded to conservative management. Plantar fasciotomy, there was one level 4 evidence, quite a large group that they said had indicated that they were satisfied, so 3/4 were satisfied. However, the Manchester group, so Pillai's group, they done a retrospective of 80, and they said there was a very long period of recovery. Poor outcomes leads to the order to suggest that the plantar fascial release is questionable. This prospective study analysing percentage of fascial release, 72% open and 28% endoscopic. And it's very interesting that the more you released, the more pain you had laterally. They felt that anything over 50%, you had a significant destabilization of your foot and you got lateral column pain. And then you have all these expert opinions on different treatments of different drilling, calcaneum and such, but none of these have held up past just technique reports. Retrocalcaneal pain. So this is the pain around this area. There's a number of different factors I said earlier. For conservative management, 4 studies evaluated, 100 painful tendons, large group unsatisfied. So for the area of the Achilles insertions, your stretching doesn't do as well as your non-insertional or your plantar fascial. Shockwave, however, does. So for all outcome measures, the group that achieved shockwave showed significant greater results. So shockwave for your insertionals do very well. This was a systematic review of this, and they did say the strengthening exercises and your shockwave, be it your strengthening exercises, is not as good as the other tendinopathies, but these are the ones that give you a grade B, where they do advise its use. The surgical treatment, so you can excise and reattach the Achilles, you can do a gastrocnemius recession or Zadex. So this one, for example, you can see a big insertional tendinopathy. You have encephalopathy with a big calcific deposit in the tendon, and this is rubbing on their shoes. You can see this in the MRI. This is extending quite high up. And you obviously remove then this area and then reinsert the tendon. And to go back to this previous review, they did show that open debridement decompression was the only one who had enough evidence to not be inconclusive. This one, 6 studies, 5 operative techniques, all showed good outcomes. 89% reported excellent to good satisfaction. And this was a mixed bag of those that were being treated open. But there was a 1 out of 5 did have complications, pretty high. Over recent years, the Zadex procedure has become more reported, where you do a wedge osteotomy of your calcaneum and bring the pull of your Achilles further forward. There's now 3 papers on this, so it wasn't in the review or previously, all showing good results, but again, only level 4 evidence. So non-insertional mid-portion. So this one, level 2 meta-analysis, all treatments, 72 articles, over 3,000 patients, 6 operative techniques, 19 non-operative. And they concluded eccentric exercise is the most supported non-operative treatment. So like the Giovanni for the plantar fascial pain, these ones are your eccentric stretches of your Achilles, and these are the ones that are the most supported for treatment. Tenotomy and debridement is the operative procedure with the most evidence. Platelet-rich plasma injection shockwave proven to be viable second line. We go through that a bit more now. And the gastrocnemius recession and fasciitis longus transfer shown to have benefits in case series. So this level 1 network meta-analysis, and this is where it becomes very interesting, these networks, so the additive effects. They show that the wait and see, these are the worst ones that do, but then acupuncture has the overall best report. But if you additive the exercise and shockwave, for example, you get better effects. This is at 3 months. At 12 months, the ones that go out to 12 months, your biggest ones are your exercise plus injection therapy on this review. This is another network analysis. And this one shows similar results where at 3 months, your acupuncture seems to do very well, as with your high volume injection with corticosteroid. It's less so without corticosteroid, and your eccentric stretching. But then on the long term, you have your stretching and your shockwave therapy, but your PRP in no factor has a favored intervention on these. Acupuncture, however, does well. Outside of these reviews, polidocanol treatment, no difference. And GTN, so put in patches on the back, all that does is give you headaches. It doesn't increase or improve your results. This is a strength study, didn't show any improved functional results, but use of customized arch supports for those who have flat feet can improve your the mechanics of your tender Achilles, but it doesn't improve your functional outcome. So surgery for, as we said earlier, level 4 evidence, open surgery showed no problems reports 11 studies, complications from 0 to 85%, success rates from 73 to 100%. So it's really difficult to conclude anything from surgery. Minimally invasive, same. Patient satisfaction, complications, success rate. It shows a little bit less complication rate as it did for the open surgery, but again, no functional results. 3 studies for endoscopic, no difference. And then for the 1 study of gastrocnemius lengthening, satisfaction rate 92%, 0 complication rate, and success rate 92%. So these don't show functional results. They're only just case series, reports on case series, and then really not conclusive. There's a level 1 study on Topaz. Topaz is it's like almost like a burning probe that you put through the tendon, compared to your partial tendon, the debridements, and this actually shows no. Sorry, my view is in the way. Showed that the decompression group actually done significantly better, but they did start off better. And if you add in FGL tendon to the debridement, again, there was no difference. The plantaris muscle is something that we haven't discussed. So there's something called the ultrasound tissue characterization, which is only used in a handful of centers in the country currently. It's very useful in delineated the area which is problematic. And as you can see here, for this very certain type, you have the plantaris insertion. So to summarize, we do have a broad range of conditions. It's very difficult to diagnose. There are many treatments for eccentric stretching as most evidence. Additive effective treatments and surgery as a low evidence for all. I thank you, and that's where I'll end.
Thank you very much, Lyndon. That's a fantastic overview.